Hello, I'm Janice Karen, the Director of Integration Technologies at the Massachusetts Health Data Consortium, or MHTC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. And if you'll go ahead and go to the first update. So excuse me. So CMS has opened up its annual submission process for new interoperability measures for MIPS. It's a long window, so now through July 1st, they're asking for suggested changes, additions, etc., to the available measures for measure year 2024. And their asks are excuse me, that they're looking to, as you can see on the slide, build on advanced use of EHR technology, focus on outcomes and promote interoperability, and reduce burden. But one of the requirements is that these are feasible to implement and can be validated by CMS. They're also looking for activities that help move towards improved health outcomes and minimize burden. So there is actually nothing that I can see on the CMS website about this. I got this via email, and the email points to a downloadable zip file, which I've linked to here. The URL for it is ridiculous. So if you're interested in learning more about this, for those of you who work on the quality measure side, you can follow that link and download the packet and take a look at that. Any questions, comments, thoughts? All right, let's move to the next one then. So this is a big one. OMB released a proposal for some race and ethnicity updates at the end of January. There's a 75-day comment period that ends on April 12th. And it's actually a really interesting proposal. The biggest change, the biggest thing is that they are proposing that race and ethnicity get combined and that they're no longer separate questions and separate data points in the way that we collect data. There's also an addition of a Middle Eastern or North African as a category that currently direct people to choose white if this is their background, but many folks in this category don't identify as white, they don't present as white to others, and so they've made the decision to separate this out as a separate category. They're also requiring the collection of a detailed identity by default. For those of you who aren't familiar, who need a quick refresher, OMB has a few top-level categories, and then there's a lot of detailed things that can be rolled up into those categories. And in general, they are pushing for the collection at a detailed level, with some exceptions, caveats, recommendations, thoughts about when that may not be the best option. The other thing that they're doing is that they are recommending the support for an open text other option if possible for that detailed. Obviously that presents some problems from a standardization, especially if you're talking about a form that only supplies 5 or 6 of the options. Something like the white category probably has, I don't know, just spitballing 70 or 80 possible options there, maybe more. So if you present 5 or 6 of them and then have other as an open text field for everything else, there may be very commonly used categories that are not written in exactly the same way. So you can find more at this link. We'll also be discussing this in a lot more detail in the main portion of one of our meetings. But for now, are there any questions about this high-level overview? All right, then moving on to the next slide. So this is a 2-slide, that's why there's no link at the bottom. Excuse me. There's a new proposed bill in the Massachusetts Senate, excuse me, proposed by Senator Cindy Friedman. That's called the Act Relative to Reducing Administrative Burden. It is primarily around prior authorization and utilization review. I did not include everything in the bill. For instance, there's some interesting requirements around school insurance plans that I did not include. But the main highlights are that all insurance plans must publish publicly all of their prior authorization and clinical review guidelines. Then they have to be consistently applied. The exception to the publication, if you license proprietary rules, you are allowed to not publicly publish them, but you must provide them to any enrollee, prospective enrollee, or provider who requests them. And for new rules, after this starts, any changes to the requirements for prior authorization cannot be implemented until they've been published in this way, assuming that it doesn't meet that exception, and all patients who are affected are directly notified. So that's the first requirement. The next one is a reporting requirement. All payers, being on the medical side or the medication side. So it wasn't clear if that was directly a PBM thing or just making that distinction generally, have to report to the Department of Insurance and publicly post every year, sliced by standard versus expedited requests. And most of these things also sliced on a per item or service basis. Obviously the first one's just a list, but the rest of them sliced that way. A list of all items and services that require prior authorization, and the number and percentage of requests that are approved, denied, or then denied but approved on appeal, the average and median time between request and determination, and the average and median time to process appeals. And then all of that information will be, in addition to the individual publication on each payer's website, the Department of Insurance has to provide an annual summary report every year by December 1st. Any questions or comments about the first part of this bill? No? All right, let's move on to the second slide then. So some other pieces that are in this bill is that there's a requirement that if a prior authorization request had been approved, it cannot be retroactively denied unless you can show that there was fraudulent data supplied as part of the approval process. This next one's interesting. As currently written, payers are required to accept and respond to electronic prior authorization requests using HIPAA-mandated exchange mechanisms. We've actually had some conversation with Senator Friedman very recently and discussing FHIR, and she seemed very open to it. And I believe, we don't know for certain what's going to happen, but it seems likely that some type of FHIR addition will be made here, and that there will be some discussion of and mention of how FHIR, and in particular, the CMS proposal might affect that. Could folks mute? Thank you. So that more to come there. And I wasn't privy to those conversations, so I can't supply any details there. But that was a promising thing. So another one that's interesting is that payers have to honor for chronic care. It's not every single PA. For something that's a chronic care condition, you have to honor the approvals of the prior payer when someone switches payers for 90 days after, at least 90 days after enrollment. And obviously that's there so there isn't an interruption in treatment as the new prior authorization process, if needed, happens at the new payer. But that's something that is not necessarily part of other laws and rules that we've seen. So that's an interesting addition. There's a requirement that approvals have to be valid either for the full course of the treatment or at least 1 year if it's expected to be ongoing. There's also going to be a giant report from a combination of the Health Policy Commission, CHIA, and the Department of Insurance that looks at basically the effects on all aspects of the system, of utilization management, patient care, provider burdens, costs, a few other things like that. There's not a lot of specifics, just sort of a general, how is this affecting the entire ecosystem? And then the last two are also interesting. There's going to be, there were no specifics of what these might be in the bill as currently written. And my guess is this would come through DOI regulatory process, but there will be a prohibition on requiring prior authorization for services and items that are considered low denial, low cost variance items, and standard treatments for certain chronic conditions. Again, none of the specifics there were outlined, but the idea is for things that should be expected or that are normal under certain circumstances or that don't, that can be planned for, those things should not involve a prior authorization process. And the last one, which is also interesting and also does not have a lot of specifics, is that the Department of Insurance would be tasked with creating standardized prior authorization submission forms for various services. So the idea there, again, is that all of the payers would have to use the same forms for common services. Any questions or thoughts there?
Well, other than the standard submission form, which is not a bad idea, where is the reduction of administrative burden in all this?
I'm sorry, John, I'm having a very hard time hearing you.
Are other
I heard yeah, that's better. Sorry.
No, I was saying I like the idea of a standard submission form, but other than that, where is reduction of administrative burden in all of this?
Did you say that we're already doing all of this?
No, I said where in this are we reducing administrative burden? Most of it seems to be increasing administrative burden.
Yeah, that's actually a good point. I think that the bill probably could have a better name. What it seems to me is that the administrative burden is sort of become a keyword for prior authorization in some senses. And so I think if you read it as reducing prior authorization and related burden for patients, I think that probably is a more accurate read. I think the idea is to have a smoother system, a system that works better. And I guess the reducing burden part, I mean, the one aspect of it that would probably legitimately be reducing burden is moving to a more automated format. And having, certain, and also perhaps having less prior authorization in total by not allowing prior authorization for a variety of services per the second to last bullet. I don't know, does anyone else have any thoughts on that? Any other comments? All right, sorry, I don't know why I had such a hard time understanding what you were saying. My apologies. All right, let's move on then. So patientsrightsadvocate.org, which is a patient advocacy group that's based in Massachusetts, has apparently been doing these semi-annual reports on the uptake of the hospital price transparency rule. This is the rule that went into effect on January 1st of 2021. So it's now been 2 full years, requiring machine readable files and plan specific pricing data for patients and a bunch of other things. So this was actually really interesting. What they found is that 24.5% of the 2,000 hospitals they looked at across the country were compliant with all of the requirements. That's actually a big jump from the August 2022 report, which was the last report, which was only 16%. So even though that sounds like a miserably low number for something that was supposed to be enforced starting 2 years ago, that's actually a pretty big improvement. And what they also found was that there are a lot of hospitals that are partially compliant. So most of the hospitals posted the price transparency files, but they didn't have complete data. They weren't in a legible format. They didn't have the price associations for the payers and plans and other things like that. There were only 6% of the hospitals that didn't have any files at all. So from that perspective, I think we're moving forward just very slowly. However, they found 21 hospitals that had been compliant before were no longer compliant. So there is some backwards motion. And 21 is actually a pretty large number if you consider that there were only 319 that were compliant last time. So that's a little bit worrying. And they point out, and we agree, that CMS has still only imposed 2 fines under this program. And those hospitals that actually got fined brought themselves into full compliance pretty quickly. And that compliance will remain low until there's better enforcement, which is kind of a no-brainer comment. Anyway, you can find the full report at the link, but does anyone have any comments or thoughts? All right, then next slide, please. And if you'll pause there for a moment. That concludes our quick updates for this week. I hope you learned a lot. If you're interested in finding out more about the DGC and its other activities, email me at dgc@myhealthdata.org. That email address is also on your screen right now.